In Chapter 8, we will be covering emergency situations and injury management. An emergency is an unexpected occurrence that requires immediate attention. This is something where time is a factor. Both my husband and I feel that a lot of people don't really understand what an emergency is until they're told. My husband works in an emergency room, and he oftentimes sees people who are coming in with an illness that could have easily waited till the next day. It really wasn't an emergency. So understanding that time is a factor when it comes to emergencies is really important. If somebody tears their ACL, it's actually not an emergency. If they tear every ligament in their knee, that could be an emergency because it could put them at risk for disrupting the blood flow to their leg or damaging nerves. So there's a difference between those two things. Somebody feeling like their knee's a little unstable but being able to walk on it isn't something that needs to be seen in the emergency room. Same thing with an ankle or something like that. Now, if somebody's ankle is twisted the wrong way, that's an emergency. Time is a factor because we want to make sure that there's no damage to the nerves or blood vessels. Most injuries are not life-threatening, but if they're mishandled, it can prolong recovery. So we're not going to tell somebody who sprained their ankle really badly to try to go out and run on it, because that would prolong recovery and possibly make it so they didn't recover completely. But even if somebody sprains their ankle really badly, if we don't have a good evidence of having a fracture, it's not necessarily an emergency. All fitness professionals, coaches, etc. should be CPR, AED, and first aid trained. As athletic trainers, again, our certification surpasses first aid training. When we are first handling an emergency, our primary concern is cardiovascular and neurological function, so heart, blood vessels, lungs, and nerve function. Beyond that, we start to look at other systems. As we already covered in our administration lecture, the emergency action plan is very important to have in place prior to an emergency so that we can have it in place to follow when we need it. So remember, separate plans should be developed for each facility. The location of the AED is going to be different, say for instance, in each building. The directions to the building could be different. We always want to identify personnel and their roles. So the head athletic trainer would provide care for the injured athlete, and the assistant coach would go and meet the ambulance and direct the EMTs to the scene and make sure and go to the hospital with the athlete. The head coach would limit bystanders, things like that. So those are how we identify personnel and their roles. We want to identify necessary equipment. So if we're talking about a gym, that equipment is going to be slightly different than in an athletic training setting. So at minimum, we want to make sure that we are identifying it and giving the location for a first aid kit and an AED. In an athletic training setting, we may also discuss other athletic supplies like tape and bandages and crutches. Everyone should know the location of the AED. Again, super important. It should be very clearly stated in the emergency action plan. So an example would be on the southwest wall of the gym between the men's and women's locker rooms. So very specific, easy to find, even if somebody doesn't understand directional terms, gives them some kind of indication of where it is, because we don't know who's going to be using the emergency action plan. We want to establish equipment removal policies and procedures ahead of time. This is more for athletic training, although EMTs would also be concerned with this. This is primarily in regards to helmet removal. So people who would be wearing helmets would be, for example, football players or lacrosse players and motorcyclists. And we want to know how and if it's safe to remove those helmets and what other equipment needs to be removed at the same time. If we remove a football helmet or a lacrosse helmet, we also need to remove their shoulder pads, because that's the best way to keep the neck in neutral alignment It decreases the chance of causing any more damage from a cervical spine fracture or neck fracture. We want to give information on the availability of phones and access to 911. So again, we want to be concerned with primarily landlines. So we want to give a landline location and telephone number for callback in case we get disconnected from the dispatch. And we want to say what number to call. It's not always 911. We want to be very clear. So don't just say call EMS in your EAP that you do for class. Say call 911 if that's the number. And if it's a fitness center, the landline is most likely located at the front desk. And again, we just want to be aware of cell phone calling area issues. Sometimes there are dead spots. My cell phone didn't work at all in our athletic training room in certain areas when I was at UCSD. And so we had to know where the landlines were to be able to call out. Staff should be familiar with community-based emergency healthcare delivery plan. So basically what that means is that we need to demonstrate knowledge of community-based healthcare, emergency healthcare in the emergency action plan. So we want to demonstrate knowledge of communication, transportation policies, and treatment policies when you are writing your EAP. So ways we can do that is stating what you would specifically, but not too specifically, say for 911 call. Don't give me an actual injury or illness. Just tell me basically what this is saying. So we would tell the dispatcher the type of emergency, the suspected injury or illness, the present condition, what current assistance or treatment or care is being given, the location of the phone being used, and the exact location of the emergency, including building and room numbers if you know them off the top, if you know them. This is one reason why when you're on college campuses and in larger facilities, it's important to call dispatch if that's how you were meant to place calls. So on Miramar's campus, we would call dispatch instead of 911. If you were calling from a landline on campus, you could call 911, I believe. Or in our classroom, you could hit the red button and that would get to dispatch as well. Other ways that you could show that you're familiar with this in your assignment would be to make sure that you're saying the proper number, make sure that you're indicating that the EMTs would be met by a staff member so that they could be directed to the area where the injured or ill person was, and also talk about providing first aid and or CPR until the EMTs arrive and take over. In the EAP, we also want to make sure we're noting who has keys to gates and locks that might not be easily accessible. So say, for instance, by the fitness center at Miramar, sometimes there are pylons in place that would block access for the ambulance to the fitness center. So we want to know who has keys to those, say, for instance, or who has keys to the gym in case it's locked for some reason. We want to make sure that for any emergency action plan that key administrators know the EAP and specific roles. So in an athletic training setting, that would be the athletic director, the head athletic trainer, possibly other individuals as well, but definitely at least those two. In a fitness center, that would be the manager, assistant manager, front desk, things like that. We should always assign one person to go with the athlete to the hospital. It's important when you're going to the hospital to have an advocate if you can, because a lot of times you can't advocate for yourself. Maybe you're unconscious, or maybe you have an altered level of consciousness and it's just hard for you to tell people what you need or what you want. The other thing is that, especially in an organized athletic program, we basically are almost taking responsibility for the individual. So if they're injured while we're supervising them, then we want to continue to supervise them until their care is turned over to a family member or a loved one. In a fitness center setting, if you are not able to send somebody from the fitness center with the injured patron or client, make sure that you call their emergency contact number and tell them to meet them at the hospital. So that's how we would note that in the EAP if we are not sending somebody on the ambulance with them. There are a couple of additional concerns or considerations when it comes to emergencies. The first is who's in charge. So athletic trainers are usually the best trained to handle an emergency in a school setting. Sometimes there may be a school nurse or somebody like that. Even if a coach is trained as an EMT or a paramedic, generally speaking, it's not their role to play at that time. So if the athletic trainer is available, they should be deferring to the athletic trainer. If an athletic trainer is not present, or if we're talking about a gym setting, a personal trainer or coach should perform first aid duties as trained until EMTs arrive. If EMTs are called, even if it's by an athletic trainer and even if there is a physician present, the EMTs will make the transport decision. So if I call as an athletic trainer, if I call an EMT and they get there and the person's improved and I say, oh, it's okay. I think they're fine. You don't need to take them. If the EMT is uncomfortable and they want to take them, they're going to take them as long as the person doesn't object. Even if a doctor is present, we actually ran into this at UCSD. We had a team physician available, and it wasn't even one of the paramedics, it was actually one of the firefighters who was an EMT, was telling the guy that he didn't think he needed to be transported on the ambulance. Now, that's pretty stupid on the firefighter's part, because if he was wrong, he put himself at a huge risk for liability, especially since the physician had already said that she thought that the person needed to be transported. But technically, the EMT firefighter didn't answer to the doctor because it wasn't his medical director. If the injured or ill person is a minor, then parents need to be informed of the accident or illness. Generally speaking, I believe that parents need to be informed if their child is over 18. So if it's a college student, say for instance, I always call the parents to let them know that their child has been taken to the hospital. I have to be a little careful about how much I tell them because of HIPAA, but I believe it's fine to tell them that their child is in the hospital. And I always start off with making sure that they know that the person is okay. We always want to say, the person is okay now, but they're going to the hospital for an injury. If you are able to come and see them, that would be good. As far as minors, parents of athletes sign a general consent to treat at the beginning of each school year. So we do have the parent's permission for the athlete to be treated at the hospital if they've signed that paper. We assume that consent to treat is implied if the athlete or child is unconscious or the parent cannot be reached, because we're doing what a reasonable person would do in that situation. Once we have identified that an injury or illness has occurred, we need to talk about principles of assessment and how we evaluate that person for their injury. Our first part of assessment that we'll do is called the on-field assessment in athletic training, because it often happens on the field or on the court when the person gets injured during a game or practice. So basically, during that on-field assessment, it's a very quick assessment. Mostly we're trying to determine the nature of the injury, and that will help provide information regarding the direction of treatment for that person. But it's very quick. We will do that more in depth than a coach or a personal trainer might, but a coach or a personal trainer could try to determine the nature of an injury as well. So most of the time, that's going to be kind of where we start. Next, we would do a primary survey. So a primary survey is basically looking for life-threatening conditions. So we want to establish the presence of and or manage life-threatening conditions. So we're going to check airway, breathing, circulation. We're also going to check for any shock or severe bleeding. So we check in that order. So we check the airway, kind of look, listen, and feel for breathing. So we open the airway first, then we look, listen, and feel for breathing. And then we would check their pulse if we're trained to do that, or we'll look and see if there's any signs that they're not having a proper pulse or if they are bleeding severely. If somebody's sitting there talking to you, your ABC check is done, your airway, breathing, and circulation check is done. They have all of those things present if somebody's sitting there talking to you. If you don't notice any severe bleeding, then it could be internal bleeding, but most likely they don't have bleeding unless you have a reason to believe that they've been hit in the stomach. And it's also fairly quick to determine whether or not somebody's going into shock. So this primary survey is very short as well. It shouldn't take very long. Our secondary survey is then after we've established that the person has an airway, they're breathing, and they have circulation. We are going to try to assess their vital signs and get a detailed evaluation of conditions that are not life-threatening. So vital signs will be things like heart rate, breathing rate, blood pressure. After we've done that, so we know that their internal systems are working properly, we will try to identify any other parts of the body that are not problems with any other parts of the body that are not necessarily associated with their primary complaint. So if somebody's been hit in the stomach, but maybe they also hurt their leg at the same time, we would want to see if there's anything else going on with that. Occasionally people will get injured and they'll say, I don't even know where I hurt. I got hit in a couple different places. So the secondary survey is checking for things that are not life-threatening, or not immediately life-threatening, but we want to make sure that the person's not going to get sicker, and we're going to look for any other outside injuries. So this is our decision-making tree for when an injury happens. So basically kind of reiterating what was on the previous slide with some additional information. So we have an injury that occurs. The first thing we'll do is that primary survey. So do they have an airway? Are they breathing? Do they have circulation? Do they have severe bleeding? Are they going into shock? Once we've done that primary survey, we'll know what their level of consciousness is. So basically, are they unconscious, so non-responsive, or are they conscious or responsive, so the person's talking to us? If the person's unconscious, that's different than being asleep. If somebody's asleep, you're able to wake them up. If somebody's unconscious, you are not able to wake them. If we have somebody who we're treating who is unconscious, we're going to immediately assume that they have a neck injury unless we saw what happened. If we didn't see what happened, we assume they have a neck injury, or if they were hit in the head or fell in such a way that they could have hurt their neck, we assume they have a neck injury. If we have a conscious patient, we're going to do our secondary survey, so do our vital signs, try to figure out what else hurts, and take a history from that person. If the person is unconscious, we've stabilized their spine. We're going to check them to see if they become responsive. We're going to check their airway, breathing, circulation, shocks, profuse bleeding, whatnot. If they have any of those problems, so if they have an airway but they're not breathing, or they have severe bleeding, we're going to call 911, access the rescue squad. If the person who's unconscious is still not responsive, but they have an airway, breathing, circulation, and they are not severely bleeding, then we'll try to do our best to get some vitals on them and just check their body and see if we can figure out what's going on. But we always want to call 911, even if the person remains unconscious. That's already a life-threatening condition, so we'll always call 911 there. After we call 911 for an unconscious patient, we'll care for the patient until the rescue squad arrives. If we have a conscious patient, we'll give treatment considerations. If somebody sprained their ankle, we don't need to call 911 for that. If somebody has So either way, once we've decided how bad the injury is, we can decide on transportation either from the field or court, or whether or not the person needs to go in an ambulance. So when we are talking about treating an unconscious person, when we are acting alone, we always want to contact EMS first, especially if it was an unwitnessed collapse. Those are most commonly in adults caused by cardiac events or heart issues, and we really need EMS there as soon as possible to bring life-saving medications and being able to defibrillate the person. Even if the person does have regular airway, breathing, and circulation, if they're unconscious, that's considered a life-threatening condition in and of itself. If we believe somebody might be unconscious, first we want to check their body position and the level of consciousness. So just because somebody looks unconscious to us doesn't mean that they are. So we'll tap them and say, hey, are you okay? And if they don't respond, then we'll try to check their airway, breathing, and circulation. So if somebody starts on their belly and they don't seem to be breathing, we're going to want to try to open their airway. So we will need to carefully roll them onto their back. And if we don't suspect a neck injury, we will raise their chin to the sky to help pull their throat, or help to open their throat, pull their tongue out of the back of their throat to open their airway. A lot of times when somebody becomes unconscious, their tongue will relax and block their airway. So once we've established that airway, then we're going to check them for breathing. So when we open their airway, did they start breathing? Normal breathing would be something along the lines of, right? Abnormal breathing or ineffective breathing that would require CPR may sound something like that's not normal breathing, and that person will require help breathing. We will also check their circulation. So we will check for a pulse if we're trained to do that, or check for any signs of life if we are not trained to check for a pulse. Those are our ABCs. If we did not witness a collapse, we're going to assume the person has a neck and/or spine injury. So we'll need to be careful when moving them, or we're going to try to protect the neck. If somebody has a helmet that they're wearing, we will need to remove the face mask. Even if their ABCs are fine when we first come to them, they could worsen quickly, and so we want to make sure that we don't have anything blocking their airway or our ability to do CPR. If that happens, we want to be able to start CPR as soon as possible if somebody stops breathing, say for instance. So continuing on with treating the unconscious person or athlete, if the athlete is supine or on their back and they're not breathing effectively, then we will start CPR. If they're breathing normally, we will wait for them to regain consciousness. If they're on their belly or prone and they're not breathing, we will log roll them and begin CPR. So we'll carefully roll them over while keeping the neck in a straight line with the body. If the person is on their stomach and breathing normally, we leave them be. So we'll wait for them to regain consciousness, and then we can log roll them and monitor their ABCs once they've woken up. But if somebody's breathing fine the way they are, we don't mess with them. We want to try to do our best to maintain life support until EMS arrives. If you're out hiking in the wilderness and you come up to somebody who is in the middle of having a heart attack and has stopped breathing and doesn't have any circulation, most likely you're going to be doing CPR for a long time. You would just do your best to keep continuous CPR until EMS arrives. It could be 20 minutes, probably longer, probably more like an hour. So you would just try to keep going until you were too exhausted to continue, or until somebody else came and helped trade off with you. As far as on-field, helmet removal should only be done by a trained individual unless the athlete is not breathing and you need airway access immediately. it's very easy to injure somebody's neck worse if we remove their helmets, but we assume that somebody would rather be alive and be a paraplegic than be dead and have their neck intact. Once the person is stable, we'll do our secondary survey. So once the person becomes conscious, then we can start our secondary survey. So next we will go over a brief overview of CPR, or cardiopulmonary resuscitation. It is so important for people to be CPR certified. I believe all of you in class should have a CPR and AED and first aid certification if you're able to. So much so that I offer you extra credit for getting or showing me that you have a CPR certification. So as far as emergency CPR, we want to evaluate them to determine a need. So if they're not breathing effectively or if they have no circulation, then that would be a sign that they would need CPR. We can get CPR certifications through several reputable companies. So American Heart Association is one, American Red Cross is another, or the National Safety Council would be another. Those are probably our top three best companies offering this. You can also find online companies that do CPR as well, or training as well. So that would be better than nothing if you aren't able to afford the classes for these other companies. So there are slight differences between the steps and the procedures for these different companies. In your book, the information presented follows the American Red Cross procedures. So that's what we'll be talking about right now. So our steps of CPR are check, call, care. Our first step, check. We're going to check the scene for safety, so making sure it's safe for us as a responder and also safe for the person. Now, if a person's been hit by a car and they're standing in the middle of the road and it's a busy street, you have to determine whether or not it's worthwhile for your safety to be running out into the street to care for them. We also have to determine whether or not it's safe for them to stay in the position they're in. Usually when we care for someone, we want to leave them in the position we found them. But if they're in an unsafe position, like in the middle of the street or out in the middle of a lightning thunderstorm, then we need to move them. Or if they're in a pool, we're going to need to move that person as well so we can treat them. We're going to check the scene for safety and then also check the person for consciousness. So the tap and shout, hey, are you okay? Then we're going to call. So if there's somebody else with us, we're going to send that person to call the emergency number and get an AED at the same time. If we are by ourselves, then we will, and we know where an AED is, then we will go get that AED ourselves and try to call on a cell phone while we're performing CPR. The cell phone will most likely need to be on speaker. So on this page, we have an overview of CPR as far as our care steps. So as far as our first care step, we're going to check for effective breathing and or signs of life. So if we are trained to check for pulse, great, we'll check for that. If not, we're just checking for signs of life. And again, the effective breathing sounds like normal breathing. Ineffective breathing sounds like or something along those lines. Then we will begin compression. So we want to do 30 quick compressions, pressing at least 2 inches deep on the center of the sternum. Next, if you feel comfortable and have a barrier, you can do 2 rescue breaths lasting 1 second each. It is acceptable to do chest compressions or hands-only CPR at a rate of 100 per minute. This is suggested as far as the Red Cross is concerned for an uncertified individual, or again, maybe you want to help a person, but you don't feel comfortable with putting your mouth on theirs, or you're worried about them vomiting into your mouth or something. Either way, you don't want to put your mouth on the individual, then chest compression only is acceptable. You want to repeat the steps 5 times, so the 30 compressions and 2 rescue breaths if you're doing them, and then recheck for signs of life, or just do continuous CPR if the person is not showing any signs of life. So again, we'll check for breathing, look, listen, and feel for breathing with our ears, and then also check for any signs of movement. We do want to use an AED as soon as it is available. So, if I were to go get an AED on my own, I would open it, I would let it start going through its prompts and everything while I start CPR. But as soon as I can get the AED attached to the person, I'm going to do that, even if it's in the middle of a cycle of CPR. As soon as it says to stop touching the patient, I'm going to stop touching the patient. The AED is so important because what we're doing with our hands is we're circulating blood in the person's body. It's slightly oxygenated still, but if we want to actually restart the person's heart, we need to have an AED, or the ambulance will have to give that person life-saving medications. So the AED is so important that after 5 minutes without an AED, the person's survival rate is very low. It could be almost non-existent. So this is very, very important. If I ever have a heart attack in the middle of class, I would hope that you guys would go get the AED as soon as possible and hook it up to me as soon as possible. There was actually an instructor at Mesa College who survived a massive heart attack that only about 20% of people survive because the students responded so quickly and so well, and they called dispatch, and one of my friends who was actually one of the campus police came, and he used the AED quickly and effectively. And the instructor, I think he technically, his heart stopped maybe 4 or 5 times. The AED read that before he got to the hospital, and he survived because the people that were caring for him did such an effective job of CPR and using the AED as soon as it became available. So as far as using an AED, AEDs are actually very simple to use if you follow the directions appropriately. The AED's job is to evaluate the heart rhythm of a victim, and if the rhythm could benefit from being shocked, it will deliver an electrical charge to the heart after you push a button. These are fully automated and they require minimal training. But they're all a little different. So the one in the picture on our slide is a little different than the ones we actually have on campus at Miramar. The ones we have on campus at Miramar are yellow and blue, I believe, and that you have to actually open the AED prior to it starting to give voice prompts. On this one, you would touch the green button to turn it on. But they're all a little different. You just have to look at it carefully to make sure you know how to turn it on. For all of them, you will put one electrode on the right upper chest and one electrode on the left lower side of the chest. In this particular AED, they're specific about which electrode they want where. So there is a photo there that tells you to put the electrode on the left on the right upper chest and the electrode on the right on the left lower chest. Other brands of AED may not be so specific. It may not matter which electrode you place where. Once the machine is turned on, the machine will say if and when defibrillations and or compressions are necessary. So the prompt from the blue and yellow machine says something along the lines of once you open the machine, it will say, remain calm. Please remove pads from the packaging and place on the victim's bare right upper chest, and then it'll say bare lower left chest. And so it really talks you through it and tries to make it easy. Again, once we have all of our cortisol and adrenaline going during an emergency, we get not as smart as we usually are. So the AED tries to be as clear as possible. And again, we want to use one of these as soon as we have one available. When I was at UCSD, one of my student athletes was working at the gym as her job, and a person had a heart attack. He was actually relatively young. He was in his 30s, and they went and got the AED, but they completely forgot to use it. They were in the middle of doing CPR and just didn't use it, and that individual passed away. It's hard to say whether or not the AED would have saved his life. He may have not even had a shockable rhythm, but they never knew because they didn't use the AED. so they just forgot to turn it on. So super duper important to use the AED. It will help direct you and will tell you whether or not the person has a shockable rhythm, and it could save their life. So once we've determined that the individual has an airway and is breathing or has good cardiopulmonary circulation, we want to control any external bleeding that we would find. So if somebody has external bleeding, the first way we try to control that is by using direct pressure. So we use a sterile gauze and gloved hands placed directly over the site of injury, and we'll press that sterile gauze down towards the bone to try to slow any bleeding. This is our primary technique. This is how we will, maybe 90% of the time be able to control bleeding, maybe more than that even. If that's not working and we don't believe the person has a fracture, we can try elevating the body part. So instead of keeping the arm in that left hand picture on the slide down, we could keep that direct pressure and try to elevate that above their heart. Basically what that does is it decreases the blood pressure that is flowing towards the arm, and it will increase venous and lymphatic drainage, so that will slow the bleeding down. If that still doesn't work, we could try using pressure points. We don't use those very often. It really depends on you being able to effectively find the closest artery, which a lot of people just aren't effective at anyways, and it may or may not really be that effective. So if we were to try to use these pressure points, we would use the femoral artery at the hip or the brachial artery in the arm, which is shown in the picture on the right on your slide. Another type of bleeding that we can have with an injury is called internal bleeding. So technically, a bruise is bleeding beneath the skin, so that is considered internal bleeding. But we're more concerned when it's in a muscle or a joint or a body cavity. Bleeding within the body cavity can result in death, so we're definitely concerned with that. It's common to get what we call a bone bruise when somebody has an injury to the knee joint, say for instance. The same mechanisms that would cause a meniscus tear or an ACL tear can also cause some bone bruising. As far as internal bleeding in the body cavity, it can be difficult to detect, and the person must be hospitalized for this. Generally speaking, what I've been told by physicians is that even 1 drop of blood in the abdominal cavity is extremely painful, and the person will be kind of about in a 10 out of 10 worst pain ever type of scenario with this. The belly can feel hard and painful, and one of the main concerns with internal bleeding into the abdomen is that, or the thorax, the chest, is that it could lead to shock if it's not treated accordingly, and shock is a life-threatening disease, illness. So talking more about shock, which is again a life-threatening illness, causes of shock could be severe bleeding, a fracture, or other internal injuries. And basically what happens with shock is that it's a result of decreased blood available in the circulatory system. So the total blood volume goes down because of bleeding somewhere else, generally speaking. The blood vessels will dilate to try to do their best to continue to circulate the blood that is still present, and the fluid in the blood gets out of balance. So basically we're having an influx of different fluids and substances into the bloodstream that really aren't supposed to be there, essentially, or not in such quantities. So what will happen then is, again, if there's not enough blood volume, the movement of the blood cells will slow because they just don't have as much fluid to float around in, and that will decrease oxygen transport in the body, which can cause widespread tissue death. So if there's not the oxygen availability for tissue, the tissue will die. Contributing factors here could be fatigue, dehydration, extreme heat or cold, or illness. So if somebody already has the flu, say for instance, and they're playing in a game and they get a fracture, then they could more easily go into shock. Signs would be moist, pale, cold or clammy skin, so kind of wet and sticky and pale. Weak, rapid heart rate, increased shallow respirations, and decreased blood pressure. So if we check their blood pressure, it will be low. They could have urinary retention, so inability to pee, and fecal incontinence, or they may poop themselves. They could feel irritable or excitable, and they may potentially be thirsty, but we shouldn't give them anything by mouth until they've gone to the hospital and been cleared for that. As far as management of shock, remember that shock is a life-threatening condition, so we want to call EMS, so 911 if that's our emergency contact number. We want to maintain the individual's core body temperature. So if it's cooler out, we want to put blankets on them possibly. If it's warmer out, we want to move them to the shade so that they don't get overheated. We want to keep the athlete calm, because getting upset can lead to or compound reactions, shock reactions. So trying to, they're not going to feel well, but trying to keep them as calm as possible, tell them it's going to be okay, that, they're going to feel better soon. And along those lines, we want to limit onlookers and spectators, because a lot of times if somebody's feeling watched, they're going to be more upset. Even if it's teammates and the teammates are trying to be supportive, it's not okay for them to be near somebody who has a problem going on, because it can make it harder for them to recover. We want to reassure the athlete, again, it's going to be okay. We don't want to give them anything by mouth, so no water or food until instructed by a physician. Sometimes people who have gone into shock will need some kind of emergency surgery to help correct the cause of shock. So we don't want to cause that to be any more complicated by giving them something by mouth. So we've now gone over our on-field assessment and our primary survey, looking for things that are very serious. Next, we're going to be looking at the secondary survey. So starting to look for something else that could be causing the person to become ill, or trying to identify their actual injury. So first we'll look at vital signs, so things like heart rate and breathing rate, blood pressure, temperature, skin color, and pupils. So checking to see if their pupils are normal, so pupils, and making sure that the pupils are equal and reactive to light. We don't do this for every single person who gets injured. If I know somebody who has literally just sprained their ankle, I'm not going to take their blood pressure. But if the person's just not feeling well, and maybe they've been hit in the head or hit in the abdomen, or there's something else that could be affected by blood pressure or heart rate or breathing rate, then I'll check those things. So not every single person gets their vitals done on my watch. Having said that, if an EMT comes, even for an ankle sprain or something like that, they're going to check their vital signs. And it is important too, because if somebody breaks their ankle or their wrist and we call EMS, they're going to want to check to make sure they're not going into shock. So that would be another time I might check it, is if they seem like they're starting to go into shock. Other considerations, if assuming that all their vital signs are just fine, we're going to look at how they're moving. Are they able to move the body part normally? Are they able to walk or point their toe? Things like that. Do they have any pain? If they do have pain, is it mild, moderate, or severe? If we're talking about a head injury or somebody who has an unknown injury, what is their level of consciousness? So do they know who they are? Do they know where they are? Do they know why they're there? Do they have any idea what time it is? Things like that. Those all give us an idea of their level of consciousness. Okay, so as far as our on-field evaluation goes, this is just an initial on-field injury inspection. So basically, we're trying to decide how bad is the person's injury and can they be moved? That's literally where we're starting. If I don't have time to do a full evaluation to know exactly what's going on, I at least want to make sure that if they hurt their ankle, is it likely to be a sprain versus a fracture? Can they bear weight on it? If they can't bear weight on it, then I need somebody to help me get the person off the field, maybe with a buddy lift or with a golf cart, say for instance, if they have that available to them. We do this by trying to figure out what their mechanism of injury was, and their major signs and symptoms. So for an ankle sprain, their mechanism of injury may be I twisted my ankle inward. And major signs and symptoms would be my ankle hurts on the outside just under the bone on my ankle. That would be essentially a brief history. And usually I would ask people, can you point to where the pain is? And they'll show me. I would look to the best of my ability to see if there was swelling or deformity prior to trying to move them as well. We can gently palpate to aid in determining the nature of the injury. So I want to know whether or not the pain is directly over the malleolus or if it's under the malleolus if I suspect an ankle sprain versus a fracture. I want to know how tender they are to the touch, how if there's any irritation or deformity. So I do want to try to touch the injured body part if I can. If it's safe to, like in this case of an ankle, if it's safe to remove their shoe, I can try to do that, although we do tend to have limited time for this on-field evaluation. So we're going to make decisions about the seriousness of the injury, the type of first aid or mobilization that we think the person needs, if they require immediate referral to a physician and further assessment, or if they can be transported to the sidelines or a quiet room, or if they need to go to the hospital. So during this time, I'm going to decide, do I have this person stay here and I call 911, or can I carefully help them off the field? Anything that we do on the field, we also want to document as an initial assessment with exam findings and actions taken, just so that we have a record of what was done on the field. But we won't do that while we're on the field. We'll do that when we get off. So we covered the quick on-field evaluation. Now we're going to talk about the off-field evaluation. This can be performed by an athletic trainer, sports physical therapist, or physician once the athlete is off the field or court. So this is going to be a more detailed evaluation. The injury evaluation is divided into 4 sequential parts. History is first, observation, palpation, and special tests. So we kind of touched on this in a previous lecture, but we're going to go into these areas a little bit more in depth in this chapter. So again, in our injury evaluation, first we're going to take a history. So we're going to obtain information about the injury, ask questions, and listen to the athlete's answers. So this would be things like, if somebody hurt their ankle, which way did your ankle turn? Or did you hear or feel a pop or a snap? Or where do you have pain? Those are all good history questions. Next, we would have observation. So we're going to inspect the injured and non-injured areas, both on the injured side and the non-injured side, so that we can see what's normal for that person. We're going to look for any gross deformity. So gross deformity is what it sounds like. It looks gross. It's one of those like, oh my gosh, that looks terrible types of differences. Swelling is swelling. Swelling you might look at it and say, oh man, that's pretty swollen. But you're not going to think, oh man, that's gross. That's terrible. That's a gross deformity. Swelling is just swelling. The other thing we're going to look for is skin discoloration. So that could be in the form of a bruise or redness. Sometimes people have a couple of different colors of skin going on. Next, we're going to do palpation or touching. So we're going to touch and press on the bony tissue and soft tissue. And we'll do a systematic evaluation beginning with light pressure and progressing to deeper palpation. And we start away from the injured area and move towards it. So if somebody hurt their ankle and I think they sprained their ankle and their pain is right below their lateral malleolus, I might start at the toes and work my way up, or start at the calf and work my way down, and start light and then just trying to figure out where they're having pain with the touch. Or also checking to see if I can feel anything that feels unusual to me. Then after that, we would do the special tests. So again, those are designed for every body region to detect specific injuries, and these will substantiate our findings from other testing. So we would do probably for an ankle sprain, if we suspected a lateral ankle sprain, we would do an anterior drawer test and an inversion test. We may also do a bump or compression test to make sure to try to rule out fracture. So those are some different special tests we might do specifically for the ankle. So after we have finished our off-field evaluation, we should know pretty much what's wrong with the person. So then after we figured out what's wrong with them, we need to treat them. So we need to do some immediate treatment for the injury. No matter what the injury is, our primary goal is to limit swelling and the extent of hemorrhaging or bleeding. If we can control the swelling initially, the rehab time will be greatly reduced, and it may actually improve the person's ability to heal completely. We control swelling primarily through a mechanism we call PRICE. So that stands for protection, rest, ice, compression, and elevation. We want to use PRICE for the first 72 hours. So that means we're trying to ice for the first 72 hours or so. So every time we treat an injury that is a new injury or an acute injury, we're going to try to use this PRICE concept. So to expand on these areas, as far as protection goes, basically with this we want to prevent further injury. So if that means that somebody sprained their ankle and they can walk on it and it's not painful, then they can walk on it. They don't even necessarily need a splint or a brace. But if they're not able to bear weight on it, we'd want to put them on crutches. If somebody can walk on a sprained ankle, we probably still wouldn't let them run on it because we're still trying to prevent further injury. So protection can mean immobilization and crutches if the person needs it, or appropriate transportation. It just depends on how bad the injury is. So our next concept with PRICE is rest. And rest means relative rest. It doesn't mean that you can't do anything with a sprained ankle. Say for instance, if somebody could still use a stationary bike if they had an arm injury, or if they had a shoulder surgery. The other thing is that the days of rest needed vary depending on the extent of the injury. So oftentimes, if you go to the doctor for a minor ankle sprain, they'll say take 1 to 2 weeks off. Well, that's a very general, broad statement. I could get somebody to be fine playing on a minor ankle sprain by having them taped enough after just a couple days. So it kind of depends again on the extent of the injury. Most people who have a moderate or second-degree ankle sprain are going to need more time off. It's just because there's more damage. Next, we'll talk about ice. And ice really means cold application, so it doesn't necessarily have to be only in the form of ice. You could also use cold water or possibly a chemical cold pack. Say for instance, that would be like ice. But generally speaking, we want to use ice as an initial treatment for acute injuries. So that's an injury that just happened. Whereas if somebody has a chronic injury, they could either use ice or heat possibly. But for an acute injury like an ankle sprain or a knee injury that somebody just twisted their knee or a muscle strain, then we want to use ice. So for strains, sprains, contusions, and inflammatory conditions, we don't want to put more fire on the flame. We actually want to put that flame out. So that's why we're putting cold on it. This ice can be used to decrease pain and promote blood flow changes. We want to ice for 20 to 30 minutes on, then take the ice off until the body part goes back to normal temperature, so same as the other side. So if we ice the right ankle, we want it to be the same temperature as the left ankle. And then we're going to repeat for the first 40 or 72 hours. Ideally, I like to ask people to try to ice 3 times a day at minimum. If they can do it more, great. That could be really helpful. So continuing with our last couple of concepts for PRICE, we have compression. So just like in that top right-hand picture on your slide, we're using an ACE wrap there for compression. We try to use compression to decrease the space that allows for swelling to accumulate. So we'll try to decrease that space either with an ACE wrap or foam or felt cut into, say for instance for an ankle, a horseshoe to help smush the lymphatic fluid out of the area where it's accumulated or where it likes to accumulate around the malleolus. And then we'll use the ACE wrap to try to push that lymphatic fluid back up towards the gastrocnemius so that the fluid can be pumped up towards the heart. The fluid that causes swelling is not blood, it's called lymphatic fluid, and the lymphatic fluid travels in vessels called lymph vessels that mirror the pathway that the veins for the blood system follow, for the circulatory system. So if we get the lymph vessels to carry the lymphatic fluid back towards the heart, it will actually dump the excess lymph fluid into the heart and it will be incorporated into the blood as a component of blood. So swelling is not from blood, it's from lymphatic fluid, but we can take advantage of pumping that lymphatic fluid back to the heart to keep it from settling into places it doesn't need to be. We want to have people wear compression for about 23 hours a day for the first 3 days for 72 hours. So basically the person can take it off to take a shower and get ready. But for the most part, we want to be wearing compression even overnight while we're sleeping when we're swollen. And if the ACE wrap gets too tight, the person can remove it and put it back on a little looser. So our last concept with price is elevation. Elevation helps to prevent pooling of blood and lymphatic fluid and aids in drainage using gravity. The greater the elevation, the more effective the reduction in swelling. So we want the swollen body part to at least be above the heart, but the higher we can get it, technically it could help more with reducing any swelling or fluid accumulation. Technically, elevation is the most effective way of reducing swelling. It's hard to do because it's hard to spend most of your day with your foot up in the air if you have a sprained ankle. Compression you can wear more of the day. But even if we can get, instead of having the foot down in class, if somebody's sprained their ankle, if we can at least get it out straight, that's better than being down. Anything is better than down, but above the heart is best. So if we are concerned with somebody having a fracture or a very bad joint injury or dislocation, then we would try to splint them instead of just giving them crutches and an ACE wrap and using price. So we would want to splint them if we could before they go to the hospital or before we call an ambulance. And we should always splint a suspected fracture before moving the person. So even if they're on the field and they have an unstable fracture, we're going to try to splint them while they're still on the field. We try not to move them off the field first. If they have a stable fracture, then we may be able to safely move them. But without proper immobilization, we can increase the damage to the bone and the soft tissue around it, and we can have more bleeding or hemorrhaging. With certain bones, we could actually have death if it's mishandled. So say for instance with the femur, the femur has a lot of blood supply to it and it also is near some major blood vessels. And if the femur fractures, it can cause a lot of damage to the soft tissue in the surrounding area. So we really don't want to move a person with a femur fracture until they're splinted. Splinting is a simple process. Basically, there's 2 rules. If we think that somebody has a fracture, say for instance in the forearm, we're going to splint one joint above and one joint below. So we need to make sure the wrist doesn't move and the elbow doesn't move if we think that somebody has a forearm fracture. That's our first rule. And then the second rule is we're going to splint the injury in the position we found it in. So if we found their arm straight, we're going to splint it straight. If we found their arm bent, we're going to splint them bent. That's our 2 rules for splinting. Next, we're going to talk about care for suspected spinal cord injury. So if we think somebody has a bad enough neck injury that we suspect that they could have a spinal cord injury, then we want to activate EMS immediately and wait for the ambulance before moving an athlete. What you'll find is if you watch somebody being cared for with a suspected cervical spine injury, that it actually takes quite a few people to move them. At minimum, you need 3. Really, it's much safer to have 6, 5 or 6. But at very bare minimum, you need 3. And you need 3 people who are very well trained and know what they're doing. So if you are treating somebody by yourself, usually it's best just to wait for EMS. The other reason I like to wait for EMS is because, I'm pretty well trained at spine boarding somebody. I've trained other people to do it. I know what I'm doing, but EMS does it, maybe 5, maybe 10 times a day. So they have a lot more practice. So generally speaking, I believe that somebody who has more practice and more experience in something should be the person doing it. Now, having said that, if somebody walks up and starts acting like they don't know what they're talking about, I'm not going to give up the head. I will make sure I keep holding the head to help direct what's going on. But we definitely want to make sure that transportation or movement of an individual with a C-spine injury should be left to trained experts. We want to maintain the head and neck in alignment with the body or in the position that we found them. So if the head was twisted to start, we don't untwist it. We leave it there. We leave it there until EMS comes and tries to get them on the backboard. As far as placing an athlete on the spine board, again, we should contact EMS if this is required. If a university or a professional team has enough staff that's highly trained in this, then they won't necessarily wait for EMS. If you see somebody from a professional football team being removed from the field for a suspected cervical spine injury, it's the athletic training staff and the doctors that are actually removing that person and spine boarding them. They practice it a ton. They know what they're doing. They don't need EMS, but at most other levels, people just aren't practicing enough to be the more skilled individual at that. When we're placing an athlete on a spine board, one person must be responsible for the head and neck at all times. So whoever is on the head is the person in charge. And they direct the other people for what they need to do. Our primary emergency care must be provided to maintain breathing, treat for shock, and maintain the positioning of the athlete throughout the spine boarding process. But basically, the person will be log rolled, the spine board will be placed under their back, and then they will be shifted until they are all the way on the spine board. The blocks on the spine board will be placed on either side of their head, and then they will be attached to those blocks using Velcro straps or tape, and their body will be strapped to the board using usually Velcro type straps or seat belts. Lastly, we'll talk about the proper fit and use of crutches. So again, the crutches is part of the protection concept when we talk about price. Crutches can be really useful for a lot of different lower extremity injuries. I don't love them for all lower extremity injuries, but they're definitely useful and needed for a lot of things. It is really important to know how to properly use and fit crutches because improper fit or use can cause falls and or additional injury. So say for instance, this is a picture of Rihanna on crutches. It looks like she maybe broke her ankle or something to that effect. And her crutches do not fit her properly. They're actually set too long. So they probably need to be 1 to 2 inches shorter than where they are right now. They just weren't measured properly when she was at the doctor. If we're going to fit somebody properly for crutches, we don't, usually crutches have a little clicker on them that tell you, oh, if you're 5'6", this is the button you use for your crutches. And that's helpful, and usually it's fairly accurate, but we also always want to measure first to make sure that, well, we can put it on the 5'6" measurement, but then we want to make sure that we measure it after that before the person leaves to make sure that it's fitting them properly. We'll have the person stand with good posture, so stand upright. We'll have them in flat-soled shoes. And we'll want to place the crutches 6 inches out and 2 inches in front of the shoe. So if you look at Rihanna's crutches there, they're way more than, especially the left one is way more than 6 inches out from her leg. It's probably more like 18 inches, and the other one is barely 6. Once the crutches are in that position, 6 inches out and 2 inches forward, we want the base of the crutch, or the part that the armpit will sit near, to be about 1 inch below the armpit. For me, that's about 2 fingers, so 1.5 to 2 fingers. And then we want the hand brace position to place the elbow at 30 degrees of flexion. So in this picture, her elbows are actually not too bad. It's just the length of the crutches that are too long. As far as walking with crutches, this corresponds to walking. So we have a tripod method where we act like the crutches are the injured leg, and we're going to, if we reach forward, so in her case with the right leg, the crutches will come forward with the right leg, and then she'll swing through with the left leg. So she's going to swing through so the injured leg doesn't touch. If you're partial weight bearing, then the foot and the crutches still move together, but now the foot has contact with the ground. So foot contact along with the crutches moving, and then swing through with the uninjured side. As far as stair climbing, after somebody can safely move on a level surface, we can have them practice stairs. This is good to do even in a doctor's office to make sure that the person can do it if they might have to go up or down stairs. Basically, for stair climbing, we want to think about up with the good and down with the bad. So if we're going upstairs, if we have a right ankle injury, the left foot will go up first, then that will be followed by the crutches and the injured foot. And then if we're going downstairs, down with the bad, then we would go crutches, left foot first, right foot would follow.